I know we have a mixture of audience members. Who are the physicists who might be present today? Just get a sense of. Great, that's really fantastic. And how many of you are actively practicing LDR brachytherapy? So many of you. So I know that some of this material then might be a review. And we're really going to try to hit the highlights for you. And you might feel like there are pieces that are missing. We did try to provide some attachments or addendums to these slides. And so they'll be in your handout packet. And I know that they have a lot of detail. And that's very intentional. It's not the only way of doing things, but we wanted to give some of you a different example of specifically what you can do in each part of the process. I'll be tasked with discussing the physics aspects of permanent prostate seed implants. I work at Mayo Clinic, and I'd like to acknowledge Firas. He's given a talk very similar to this in past ABS talks, and so I borrowed some of the content and tried to incorporate that. Nothing to disclose except that I wanted to comment that I do provide some equipment examples, and it doesn't imply endorsement of the products or assurance of safety or regulatory compliance for your state or nation that you're working. 3 objectives. First, review the basic concepts for starting your permanent prostate seed program. Number 2, discuss how a comprehensive QA program can help to ensure quality and safety. And then 3, describe pre-implant, implant, and post-implant procedures. And I won't get all of those, and that's what those appendices are for, so that the parts that I don't have time for today. All right, so we'll start out here with permanent prostate seed implants. And these are low dose rate, they're low energy. So you're looking at dose rates that are somewhere between 0.4, that's more like an iodine type treatment, and then the 2 gray per hour is getting closer to the sort of cesium half-life. They're less than 50 keV, and here are 3 different isotopes that are available. All 3 of these isotopes are effective. They do have differences in half-life, and that means that they have different prescription doses. Slight differences in energy, which changes a bit how you plan, maybe how many seeds that are used. But you really can't go wrong with any 3 of those. They're all fantastic. Firas mentioned that I'll be discussing a quality management system. And if you imagine then that what you have is you want a high-quality implant, and that depends on having a high-quality program. And that really is going to be having high-quality procedures and processes. And so I want you to focus that that's kind of your role, is that in the end, that does lead to a good impact and outcome for the patient, but it all really starts at the beginning with commissioning and the physicists. So commissioning your program, that'll be the process by which the equipment, the facility, the plant, this is a generic process, not just radiation oncology, where you test to verify that it functions according to its design and its specifications. The elements that we'll have in radiation oncology is we're going to try to intercept some potential problems or errors. And we want to prevent errors in hardware or in software or even in people, such as lack of training. And also the organization, including communication. There are procedure documentation and safety culture issues that can lead to organizational failures. So all 4 of those are roles of commissioning. It's not just checking your hardware and software. So Firas gave us this outline, and this is a breakdown then, I think I got a little mouse here, of commissioning steps. And so it's going to start first with the notion of looking at guidelines. There are a lot of consensus literature that you can read. After that, establishing your clinical workflow and your procedure. Then you've got treatment planning system, imaging, and equipment QA. You have radiation safety and regulatory compliance. You have staff training and patient training. And that's it, but that's a lot of things. And so we'll quickly walk through an overview of what's involved there. And my goal is that when you leave, you will say, I don't have to worry that I'm going to forget something or miss something, that I can go back to this. Might not have all the detail, but I didn't miss that huge chunk of the commissioning process. So all right, step 1, reviewing of consensus literature. There's a lot of it from ABS and AAPM, and here's a breakdown. I see bullet points show up very strangely from a Mac to a PC. I apologize for that. And so it's going to take you a little while to read these, but the good news is there is fantastic literature to support you in your LDR practice. Step 2 is going to be establish your clinical workflow. And in general, there are 2 planning approaches, what we call the pre-plan approach, where you simulate and plan prior to the day of implant. And I feel like that has advantages in decreased OR time and costs, as well as a decrease in stress on the implant team, just one less thing you have to worry about on the day of implant. The other approach is the intraoperative approach, where you simulate and plan immediately prior to the implant, and that gives you very consistent patient positioning for treatment planning and subsequent treatment, and you can even monitor the dose as it's being delivered. So there are really pros and cons to these. People have done both workflows very successfully, and as an institution, as a team, you have to decide which one that you favor. Here's a real basic outline. So you have pre-implant, implant, post-implant. That's how you can visualize your process. And in pre-implant, you'll be working out your workflow with, I have imaging, there's planning, seed ordering, there's assaying QA. For the implant, there'll be patient positioning, intraoperative imaging, seed placement, and then documentation. And post-implant, there'll be seed management and imaging and post-plan generation and documentation. And then within each one of these steps, you're going to have your own procedures that detail exactly what the roles are. For us, presented this fishbone diagram, and this is from Bruce Tomadsen. It's just another way of visualizing all the process steps. And as Firas mentioned, this sets up that TG100. That is, what can I think might happen? And I'm curious, how many in the audience are using an incident learning system in your clinic? Maybe external beam or brachytherapy. That's fantastic. So that's the other side of it, and that is that you can't predict always what mistakes you'll make. So if you have an outlined procedure here, you make your best guess, and then you feed back. You collect data about what is working and what isn't working, and use that to evolve and change your process, provide new levels of barriers to intercept the failure modes that you've now have discovered. Imaging and treatment planning system QA is the next step. And there are these physics factors we highlight that impact your LDR prostate implant clinical quality. You have to have imaging modality fidelity. If you've got bad images, you're going to get a bad implant. And your contouring accuracy is also imperative. Next, you have to localize the seeds accurately, and you need accurate data. These are really common sense, and so I'm just mentioning them on the offhand that you didn't think that this might be an essential component. And finally, that you have dose model assumptions. If you use the wrong dose model or the wrong half-life in that procedure, you selected the wrong isotope, if you're a center that uses multiple isotopes, then you're going to have a problem with the quality of your implant. So the quality assurance for the clinical radiotherapy treatment planning, if you evaluate the treatment planning system, I've tried to break down what AAPM TG53 said, and I felt like there were just 5 basic categories that they were hitting. And so the first was that they said that they wanted to check the image import. Is it accurate? The second is related to registration. If you're using an MR or other modality, that it's registered properly. Third, contouring accuracy. Fourth, dose calculations. Fifth, plan evaluation, including how the dose is displayed, the deviation, printout accuracy. Of course, TG43 is the most commonly used algorithm for calculating dose for low dose rate implants. And you can find data from TG43 from the AAPM IROC database. And I would encourage the users to also cross-check their data against the primary literature, the Monte Carlo, or the measurement. That is helpful to familiarize yourself with exactly where that data comes from. TG128 is guidance for ultrasound QA, and it provides there is a commercially available phantom for performing TG128 tests to evaluate the accuracy of your image. Here's a quick breakdown of, it's not a short list, but you can accomplish all of these tasks in a half a day or to a day. Okay, so after you've finished what you might consider to be the more hardcore clinical commissioning steps, you're not done. And the next step in commissioning is to consider radiation safety, staff training, and then your patient information. You will have regulatory responsibilities, and knowing those will keep your program from being fined or potentially shuttered by the NRC. It's imperative to have the license. And Firas, thank you for sharing that. It's the first time I think many physicists in this room have seen what a license application looks like, in part because they might have a dedicated radiation safety team. You are responsible for having a method for ensuring that your dose calculations are accurate for each case. That would be a dose second check. You'll be responsible for having a survey meter that has been calibrated, that you have to have a process for receiving sources and tracking those sources, the source assays, if you choose to do an assay and it is recommended by AAPM, there are requirements for what the technology specifications must meet, patient surveys and release criteria, and then of course written directives, what should be documented. And many of you, I'm not sure how many people already knew that the NRC requires that you have a copy of written procedures which demonstrate how you will ensure that what's specified in the written directive is actually carried out throughout the implant. And you have to maintain those. So if you're editing these, it helps to have some sort of way of tracking your changes so you can show them what 3 years ago your procedure looked like when you did that implant. Staff training in radiation and handling is also managed by physics staff during commissioning. So if you have an independent radiation safety team, this would be the time to engage them in the process and discuss those distribution of responsibilities. The staff will need to be monitored for radiation exposure. That's the first bullet point here. And you should have procedures for handling the high readings or how you'll annually review what the badge readings were. All process steps and equipment should have written procedures. I counted our LDR and HDR procedures at Mayo Clinic, and we have over 400 different procedures. And we have a process for creation of documents, for review of an initial document, as well as for updating documents and editors who are responsible for those. You'll find that end-to-end testing, you'll get a chance to work with some phantoms throughout the rest of today and tomorrow, and you can use those phantoms for end-to-end testing, and I think that is a fantastic way to ensure that your quality is being met. So when your program opens, I recommend these ring whole body badges. Anybody who is going to, identified by the organization as potentially receiving dose, so obviously radiation oncologist, but you might have a physicist, you might have a technician who is working with the seeds in the OR, maybe a nurse technician or a surgical tech, and all of those individuals you can badge. If you're using fluoroscopy, of course, you'll want to badge everyone for the fluoroscopy. And so the question always then is, what do you do with those results? And after time, you can assess that some people might be receiving no dose. And if you feel there's no risk that they're getting greater than 10% of our annual limit, they no longer need to be badged. And you can use your discretion as your practice evolves. Radiation surveys are required by law to release the patient after implant. And the release criteria can be found in the NRC new regs. Additionally, it's best practice to survey the room afterwards. So the first part is survey your patient and document it. The next part is survey the room, and you might think it's just sufficient to do a source inventory, and you always should do your source inventory. I know in particular we had an instance where a seed that was cut, we had a strand that we cut in the OR, and the seed fell out of the back end and fell onto the floor and rolled under the table. And it was the old vicral sutures, and it was a little bit hard to distinguish seeds and spacers. And so it was caught during the survey of the room as opposed to the inventory. So I do strongly recommend that you survey anywhere where the seeds might have been, and the carrier itself, any of the trash where they had maybe the dressings or the parts from sterilization, survey the floor, survey staff who leave the room. Here's a survey meter for those. I hope everybody has seen this. We should have a lot of board certified people here. And room surveys, you can use a Geiger, you can use a sodium iodine probe. You need to maintain those records for 3 years, including your written directives, your source tracking, your assays, and as well as your procedures and your QA. And I've got a little bit of time left, and I can't get to all of the process steps, but I wanted to hit some of the highlights when it comes to treatment planning. So let's start with kind of pre-planning. That's the area I'm going to focus on for the remainder of my time. And there are pros and cons. So pros, improves efficiency in the OR. You can customize the seed activity to the implant, the dimensions of the prostate, and it might minimize the quantity of unused seeds. You might not have to order extra in anticipating what the gland might need. Cons are that it will require an additional imaging procedure, and the gland size and position might be different than the OR. So let's walk through this. So pre-planning, a consistent setup between the pre-implant positioning and the OR patient positioning is essential. And that will be the leg position, the pelvis. You want to ensure that how the hips are rolled is consistent, as well as where you position or inflate the balloon, so that in this case, you have a transrectal probe where you can insert a little bit of water, kind of move it up and down. You'll want that probe to be good and level, and we set the mid-gland base of the prostate at the 1 row. That's how we've defined it. And we do that during our pre-imaging, and we do that then in the OR so that we have consistent setup. I have pre-planned dosimetry goals, and we aim for reducing dose to the rectum, and then there's some prostate goals. This is related to target coverage. This is some control of hot spots. Let's go back up again. And then the D90 quantity is probably going to evolve over time for your practice, depending upon your clinical experience with edema and seed placement uncertainty. We've used 115 to 120% of the prescription dose as an example. And PTV, this is the V100, greater than 95%. And well, if you can do better, that's ideal. And then urethra, our pre-implant imaging doesn't have a catheter. We don't catheterize the patients for that. So we just try to avoid dose within a central region, and I'll show you some of that in our what I'll call the pro tips. So all right, pro tip number 1. Avoid, and when you talk with other people, please do, because they're gonna have different pro tips, and these might work for you, and they might not work for others. But I figured you came here to try to understand exactly how we do things, and get a sense of at least what a few differences are among the centers. So this is N of 1 center. We avoid adjacent needles in order to prevent confusion in the OR. It's helpful. It gives you a little more flexibility to adjust them also in the OR if you've got a little space between them. So in our pre-plan, we use some of these that are kitty corner, but we try not to stack too many that are right next to each other. Our pro tip number 2 is we like stranded seeds. And this was a great study. Brian Davis, who's in the audience and will be presenting and working with you in the Brachytherapy journal, looked at what happens with loose seeds versus the vicral strands, and you can get to a point where you have no migrations out of the local field once you use stranded seeds. So that's our pro tip number 2. And pro tip number 3 is related to that we try to plan seed strands that pass through a portion of the prostate, that it's more robust to holding on than the kind of mushy space that's surrounding the prostate. So as much as possible, we try to keep them in the prostate gland, or at least passing through a portion of the prostate gland. Occasionally, you might load a needle that's outside because we also favor symmetry, or maybe because it's got a strange shape. Pro tip number 4, we avoid needles in the D column. So D is here. If you haven't ever used a grid, D is this middle column. And the urethra lives in that middle column generally, so we avoid needles where the urethra might be. Related, pro tip number 5, the only needles that we allow in the little Charlie and little Delta columns are up here at the row that demarcates the anterior border of the prostate, as well as down here where it's below the urethra. And that's to keep this region clear so that we don't have 150%. Nice wide open landing space for the urethra. Tip number 6, we avoid seeds that, now this is a slice that is the most superior, so it's near the bladder. And we avoid seeds up here, so it's a little horseshoe. It doesn't actually close all the way up. It means you get a little bit of a cold spot here. And that's because the bladder will interfere with the placement of those seeds as you try to push them. And the nice part is you don't really need much margin there because you're going to push those seeds all the way till they're at that junction of the bladder. The analogous side, if you go to the apical side, is to avoid seeds in the 1.5 row. That's the posterior row of the prostate apex. So this region right down here. And that's because the posterior surface here where the rectum has a tendency to rise up as you move apically. And so we don't want seeds which might migrate into the rectal wall. Tip number 8 is that seeds should be within 5 millimeters of the PTV. And it's very tempting to make a plan where you make a pre-plan and you push all the seeds far out laterally. It makes it fairly easy to not have dose in the urethral region, and you get this nice homogeneous pattern. You get a lot of coverage. But you're setting yourself up for potential failure, that you can't get the needles in those locations because of pelvic arch interference. And so you can use a little 3D visualization to just try to make sure that your seeds are in or near the PTV, kind of this 5 millimeter rind around the prostate. My tip number 9 is that seeds should be within 5 millimeters, or greater than 5 millimeters, pardon me, from the rectum. And because we put the posterior aspect of the prostate at this 1 row, if we keep our needles in the 1.5 row, that's a nice way of ensuring that you'll always get that 5 millimeters. And then tip number 10 is break any of the rules you need to get good dosimetry. So my last 2 slides are, after you've done this plan, it's very good to sanity check that you've done things right. I like using nomograms. I find that that's a helpful way to ensure that you have the right amount of activity. And so you have a relationship between, the amount of air kerma strength for your dose prescription, and there's some nomograms available. I think I attached a different one that I have some experience with iodine. And then here is some other ones. This is an iodine nomogram. In literature, you'll be able to find other nomograms out there. And so it's just total source strength versus prostate volume. And you'll see there are differences, and that's okay. And these differences are because institutions plan differently. Some are more peripheral, some are more central. And so as you build your expertise, I think it's very, very helpful to consider how other people have done it, but don't be afraid to learn from your own practice. And I know when we did our first cesium implants, I want to thank Stephen Frank and his team, because we actually sent them a copy of our initial plans. They looked them over and gave us a little bit of feedback. And I'm sure the other faculty in this room would be happy that if you wanted to send them, kind of initial plans to some of the physicists, we could give you some feedback and might have some other helpful tips. Thank you.